Yes.
Thank you.
All right, if any time you need a break or, you just let us know and
Okay.
we'll take it. Madam Court Reporter, would you swear the witness, please, ma'am?
Before I proceed, I will ask counsel to agree on the record that there is no objection to this deposition officer administering a binding oath to the witness by video conference. Please state your agreement on the record, starting with Mr. Potts.
James Potts, no objection.
Heather McGrady, no objection.
Zach Keen, no objection.
Ma'am, would you raise your right hand, please? Do you solemnly swear or affirm that the testimony you're about to give will be the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Thank you.
Good morning.
Good morning.
Tell us your name, please.
Anita Haugabrook,
Can you spell that, please?
Anita, last name Haugabrook.
And would you pronounce your last name for me?
Haugabrook,
Haugabrook.
yes.
And do you have a middle name?
Devon, D as in David, E capital VON.
Employed?
I am employed, take that back. I'm currently employed, per diem with Piedmont Hospitalist. And I've recently started back in the outpatient setting at Family Practice of Conyers. So I'm part-time there, and then I do hospitalist work to fill up my other time.
Right.
And I also do, just for clarification, I also do locums, travel work for hospitalist.
What, locum? Work?
Locums work for hospitalist.
I want to make sure I get this. You're a hospitalist where currently?
At Piedmont Noonan is my assign. I'm credentialed throughout the Piedmont facilities, but Piedmont Noonan is my primary location.
Yes, ma'am. So that's one, right? What?
Sir?
That's one area of your work.
Yes,
And you also work in a family practice, is that right?
in a clinic, yes. I just started that the end of last year.
All right, end of 24.
Correct.
And what is the name of your family practice
It's
group?
Family Practice of Conyers.
And there are other physicians in that group?
There are, yes.
And the third one is locums work, locum tenens?
Yes.
And who employs you to do that?
It is agency based, so they're the most recent agencies I've worked with are Global Medical Staffing and Locums Choice.
Okay. And is your work at Piedmont as a locums tenant?
No, it's not. Actually, up until December 27th, I was part-time employed at Piedmont, and I just shifted to what they call per diem, or like I just pick up shifts, but it's not through an agency. It's directly through Piedmont.
Yes, ma'am. Do they perform cabbage surgery at Piedmont Noonan?
They do not, no.
Okay. And do you know what cabbage means? CABG,
Yes.
a bypass graft? Yes, ma'am.
Yes.
And what is that?
Coronary artery bypass graft.
Yes, ma'am. And whenever I use cabbage, we both know we're talking about a coronary artery bypass graft.
Yes, sir.
Yes, ma'am. Did you bring any documents with you to your deposition here today?
I did not bring any documents. I sent them ahead of time.
That,
I didn't bring any with me. I emailed them to my attorney.
Okay. Did you have a list of what you emailed to your lawyer?
I do not. It was essentially just my notes, handwritten notes that I made when I was going through the depositions and the medical records. So just my handwritten notes. And then I also gave them my fee sheet and my list of previous cases that I've been involved in.
All right. Have you ever been a party to a lawsuit?
Party involved, like as in myself? Have I
Yes,
been?
sir.
I have well, yes, there's one that's pending that was filed in August of 2022, if I'm not mistaken, against me. A
Yes,
medical
ma'am.
malpractice,
That's a malpractice case?
correct.
Do you know the name of that suit?
Gosh. If you wouldn't, yeah, I can't remember it right
That's
now.
okay. We'll get through it.
I cannot remember her name.
Okay. Does Burns ring a bell?
Burns, yes, Nicole Burns.
Okay.
That's it.
I'm going to show you what we're going to mark as Exhibit 1 to your deposition. What I'm going to do is I'm going to pull these up for you to see them. If at any time you can't see them or need them larger, let me know and we'll do what we can so that you can see them.
Okay.
I'm also going to share these on the screen under the share.
Okay,
So that you've got access to them then. If you want to open that up, you just click it and expand it on your machine as well.
okay.
All right, I just shared your CV via chat.
Where did you put it?
Chat, did you not get it?
Got it.
Got it. And now I'm going to share it on the screen as well.
Okay, got you. Let's see what
I'll show you what's been previously marked as Exhibit 1 to your deposition.
Yeah, close that. There you
Okay.
go. Yeah, we see it.
Okay. And have you ever seen this document before?
Yes, that's my CB.
Okay. And does this accurately reflect your education, training, and experience? I can,
Does. Mm-hmm.
and it's one page, right?
Yes.
Let me, here, so I can do a better job.
Actually, it's more than one page. I think it's.
It's got your
Yeah,
qualifications,
yeah.
education, and work experience. Is that right?
Uh-huh. If you can go to the bottom, let me see if.
Yes, ma'am. Hospital affiliations and board certification.
Okay, that's not my updated CB.
Okay. And what does your updated CV have that this doesn't have?
Like that, it doesn't have, I have my locums, information on my updated CB, like the
Yes, ma'am.
the healthcare systems I worked in and my additional state license.
Your additional state license?
Yes, when I do locums, I have to get licensed in other states.
Got it,
outside
got
of
it.
Georgia, so I have, I think 4 active license right now,
All right,
but I can certainly send the updated one to you.
that'll be fine. Have you ever given a deposition before?
I have, yes.
And about how many times?
I believe this would be my 4th or 5th one.
Okay.
I think today would be my 5th one.
And are those as an expert witness?
Yes.
You ever given a deposition as a party to a lawsuit?
Not as a party to a lawsuit. I was deposed in a case in Carrollton, and I can't remember the time frame. A surgeon was getting sued, and I was a part of the care team, but not named in the lawsuit. And so they asked me to come in and give my testimony
As a witness?
as a witness, correct?
I'm going to show you what has been marked as Exhibit 2 to your deposition. And this is that complaint we were talking about.
Yes,
It's Nicole Burns versus Anita Haugabrook, MD, and that's you, Anita Haugabrook, MD.
correct.
And that's a medical malpractice case,
Yes,
and that's currently pending.
yes.
Any other lawsuits that you're
No.
party to? Show you what's been previously marked as Exhibit 3. This is a screenshot regarding the Burns case where it's pending. And it reads here, the plaintiff, Nicole Burns, you see that? I can make
Yes.
that bigger. And Anita Haugabrook Health LLC, that's you, right?
Yes,
You see over here where it reads attorneys,
yes,
and it looks like your attorney is Paul Wethington, is that right?
that's correct.
And that's with the Wethington Law Firm?
That's correct.
That's the same law firm that Heather's employed with, the Wethington Law Firm?
Yes,
So you're giving an expert deposition here today, and you're being employed by the same law firm that represents you in your currently pending medical malpractice case. Is that right?
that's correct. Yes, I've done previous cases with the Wethington firm, which is quite frankly why I chose Paul to represent me.
All right.
Their work. So I accepted this prior to my lawsuit.
Prior to. You accepted what prior?
I accepted this case, like I agreed to
Got it.
participate in this case prior to my lawsuit.
Got it. Those are exhibits, let's see. 2 and 3, is that right, Madam Court Reporter?
Yes, your next one is 4, will be 4.
Yeah. Tell me what documents you reviewed in preparation for your deposition here today.
I reviewed, of course, the affidavit, the medical records that were sent from Kennestone involving the patient, and multiple depositions. I don't know if I could name them all because there was multiple nurses, and then I know there was Dr. Klass, the hematologist, Dr. Camphor, the hospitalist, Dr. Mayung, the cardiothoracic surgeon, the cardiologist whose name is escaping me right now, McKee, and then also the pulmonologist. And
All right.
then there
Coming
were,
up.
I'm sorry, there were
I
multiple.
apologize. Go ahead.
I was saying there was multiple mid-levels too, and their names will come to me, but they escaped me.
Have you had any conversations with anyone regarding this case other than your lawyers, either Paul Wethington or Heather?
No, I have not.
Just for clarification, I'm not her lawyer for this case. We've retained her as an expert.
Your firm's representing her in the current medical malpractice case, though.
Yes, a case that was filed after she agreed to review this case.
Okay. And you're aware that your deposition is a public document
I am, yes,
and it's being videotaped?
yes,
Madam Court Reporter, it is being videoed, right?
Yes, it's recorded.
Thank you. And that it'll be available to your boards?
yes,
And it stands for you beyond just this deposition?
Yes,
Be available to other physicians
yes,
that you may work with,
yes, yes, sir.
nurses, PAs, NPs, things like that, people like
Yes.
that. And your boarded by the internal medicine, is that right?
That's correct, yes.
Also in pediatrics?
No longer board certified in pediatrics.
All right, when did you relinquish your boards in pediatrics?
I think it was 2009.
All right, and tell me how that happened.
So I trained and got board certified in internal medicine and pediatrics, a dual program. And then when I was in private practice, then when I went into inpatient hospitalist medicine, I was only doing adult care, so I opted not to recertify for pediatrics.
Okay. So that lapsed, is that right?
Correct.
And that was in 2009, roughly?
I think it was 2009.
Okay. And you're not board certified in hematology,
No,
right? And you don't have any training in hematology?
no.
Um,
Outside of what's encompassed in internal medicine training.
And when was your internal medicine training?
I did my residency in 91 through 95.
Okay. So that's about 20 years ago, is that right?
Correct.
And same, you're not boarded in cardiology?
No,
No training in cardiology?
outside of the scope that's covered in internal medicine, no.
You're talking about your medical training 20 years ago, right?
No, so internal medicine encompasses multiple what that now called subspecialists. So we are trained to identify and treat certain cardiovascular diseases, hematology diseases, endocrine diseases, all those. And then we call in the specialist when it is something that is more complex than the what is deemed to be treatable by internal medicine. Great example would be diabetes. It's an endocrine problem, but we manage it all the time. And then if it becomes complicated or complex, then we refer to an endocrinologist.
Yes, ma'am. And you manage patients with diabetes outside the hospital?
Yes,
You're not board certified in surgery or cardiothoracic surgery?
no, sir.
And you don't have privileges to perform surgery,
No, sir.
cardiothoracic surgery,
No, sir.
cardiology,
No, sir.
hematology,
No,
and you're not a pathologist,
no, sir.
not board certified in pathology,
No,
ever performed an autopsy?
no.
Okay. And do you have any fellowship training other than in internal medicine?
No,
Okay. So you don't have fellowship training in hematology,
no,
cardiology,
no,
surgery,
no,
cardiothoracic surgery,
no, sir.
or pathology,
No,
right? Your training does not include any specific focus on heparin-induced thrombocytopenia or HIT.
no,
Have you ever treated a patient for heparin-induced thrombocytopenia or HIT?
yes.
Okay, when was that?
Oh, goodness. I couldn't give you a date. I would tell you on average, I might see 2 cases a year on the inpatient side.
Yeah. 2 cases. In that sense, is that inpatient or outpatient?
Inpatient.
Okay.
And I've had patients that have come in that have been previously diagnosed with HIT that we have to, manage a little bit differently.
And that's at Piedmont Noonan, is that right?
Piedmont Noonan and in my locums capacity.
Okay. And of course, at Piedmont Noonan, none of those cases are secondary to post-op and a cabbage surgery.
That's correct. But I have been involved in the care and such patients at SSM on a locums facility, at a locums facility in Missouri. They have cardiothoracics at their DePaul site. And so we were involved in the care of those patients, and I do distinctly remember taking care of one at that time.
Okay. And what is the name of that hospital in Missouri where you do the locums work?
It's, the entity is SSM, but their DePaul site. They're
And
kind
SSM?
of like Piedmont, yeah, SSM DePaul. They're kind of like Piedmont that has a bunch of, one big umbrella and a bunch of different hospitals. So it would be SSM, and then DePaul is the particular site.
And you were a hospitalist for a post-cabbage patient at SSM DePaul?
Right. We have hospitalists. It's very similar to this setup where they are taken care of by the ICU and the critical care teams. Then when they come to the floor, we're involved in their care.
And did that patient survive?
They did.
And you were on a team of physicians?
Correct.
And that team included?
The cardiothoracic surgery team. I believe pulmonology was involved in his care, and then cardiology. And subsequently hematology once the diagnosis was made.
So the team included cardiothoracic surgery team,
Yes,
pulmonologist,
if I remember correctly, pulmonology was still on board.
cardiologist,
Yes,
and hematologist.
yes.
Other than that HIT diagnosis, any other participation in the diagnosis of HIT?
Not specifically in cardiothoracic patients.
Okay. So do you remember when that one patient was?
I don't remember the dates exactly, but I was there. I remember working there pretty extensively in 2018.
So you think it may have been 2018,
I'm thinking it was 2018.
roughly 6 years ago?
Correct.
Do you ever prescribe heparin?
Yes,
How often do you prescribe heparin?
quite frequently. Most all of our med surg patients are on heparin or either Lovenox for DVT prophylaxis.
Okay. And those aren't post-operative patients though, right?
Not most of them are not. Certainly not cardiothoracic post-op. Now they may be post-op a general surgical procedure.
And zero cardiothoracic though, right?
Correct.
Have you conducted any research on HIT?
In preparation for this case, I did do some online research. I believe I submitted a couple of articles that I kind of honed in on, but just in general researching management of HIT.
So you, in
More
preparation
particularly
for
in
your
cardiothoracic.
deposition, I
Yes.
apologize.
Mm.
In preparation for your deposition here today.
Yes, and yes, I'll say that. That's correct.
Okay. And any research other than in preparation for your deposition here today?
No,
Okay. Any training since medical school on clotting disorders?
no,
You agree that HIT as a clotting disorder?
Yes.
Have you ever ordered a HIT panel?
I have.
About how many times?
I would say maybe 10.
10 since you've been practicing medicine?
I'd say that'd be on the safe side.
Okay. And you've been practicing medicine for about how many years?
Ooh, we were just talking about that. My 30-year class reunion is this year, so.
Wow, congratulations.
Thank you.
So your best estimate's about 10 and 30 years, is that right?
Yes, in terms of, the question was in regards to treating or ordering HIT. Can you refer?
Yeah, ordering a HIT panel, we're talking about.
Or ordering a HIT panel? I would still say 10,
Okay,
for me personally.
yes, ma'am. And you agree that when you suspect HIT or heparin-induced thrombocytopenia, the standard of care requires you to order a HIT panel?
That's correct, yes.
And you do that immediately upon your suspicion?
So I wouldn't say immediately. There's typically a scoring system, and I'm sure we're all familiar with the 4T
Right.
score. And so it gives you a probability of whether or not the drop in platelets or thrombocytopenia would be related to HIT. And if the probability is over, if it's intermediate or high, then that would prompt you to order a HIT test. In other words, we come across thrombocytopenia, I would say often, but does it meet the criteria to get a HIT test? Not always.
Yes, ma'am. So what you're talking about now is the 4 T's, right?
Yes.
And when you get numeric value that's indicative of an intermediate or a high probability of HIT or heparin-induced thrombocytopenia, you're required to order a HIT panel.
Yes, sir.
And you're required to order a HIT panel whenever you suspect HIT.
Object to the form.
You may answer.
Again, if the HIT probability is intermediate or high, yes.
Okay.
And
And
HIT can be on your differential when you see thrombocytopenia, but not all of those require ordering a HIT panel.
say that again, please.
I said, oftentimes when you see thrombocytopenia, the diagnosis of HIT will be in your differential diagnosis, but again, whether or not you pursue testing for it depends on the probability of it being HIT.
Okay. You agree, though, that when you suspect HIT, you have to order a HIT panel, a test?
No.
Object to form.
Okay. And cite from any treatise, textbook, peer-reviewed article, non-peer-reviewed article, grand rounds, throwaways, anything at all that suggests that you can suspect HIT, heparin-induced thrombocytopenia, and don't have to order a HIT lab or HIT panel.
I'm sorry, I don't understand the question.
Sure. Would you read it back, please, Madam Court Reporter?
And aside from any treatise, textbook, peer-reviewed article, non-peer review article, ground rounds, throughways, anything at all that suggests that you can suspect HIT, heparin-induced thrombocytopenia, and don't have to order a HIT lab or a HIT panel?
Yeah, I'm sorry, I'm still not. Is there a way you can rephrase it? I understand that you're asking about textbook and stuff, but I'm not sure if you're asking me not that I should not order.
Yeah, I'll see if I can do a better job. You said you've ordered a HIT panel,
Yes, sir.
and infrequently, but you've ordered that lab, right?
Yes,
And you agree that the safety of your patients is paramount?
yes,
And the last thing you want to do is needlessly endanger your patient.
yes, correct.
And that's particularly with when you suspect something like HIT, right?
Yes,
HIT is a serious disease process.
I agree, yes.
And if it's not timely treated, it can kill a patient.
The complication from HIT, yes, I agree.
Well, complications include death.
Yes,
So when you suspect HIT, you certainly are capable of ordering a HIT panel, right?
yes,
What that HIT panel would enable you to do for your patient, for the safety of your patient, is rule out heparin-induced thrombocytopenia, right?
yes,
Or confirm your suspicion.
yes.
And there's no significant downside to ordering a HIT panel, right?
Object form.
Yeah, I have to disagree because there's a lot of false positives with the HIT panel. And so there are some detriments. That's why we use the scoring system, so that even if you're entertaining the diagnosis, if you use the scoring system and it's low probability, you wouldn't order a HIT panel and take the risk of getting a false positive and then, putting the patient at risk for complications from treating something that's not necessarily there.
So you said the risk to your patient is a false positive, is that right?
Yes,
What other risk is there for your patient in ordering a HIT panel?
that's the biggest risk. If you're treating something that's not legitimately there are risks to treating HIT. There's bleeding, complications that can occur. So you certainly could put them at risk.
You said that's your biggest risk. What other risk is there?
That's the risk of ordering a HIT panel. Yeah, that's the risk.
Have you ever ordered a Doppler for a patient when you suspect heparin-induced thrombocytopenia?
No. I'm assuming you mean the Doppler of the lower extremities, like a Doppler of the ultrasound of the lower extremities Doppler?
Yeah, well, that's one basis, yes.
No.
Did you review the policies and procedures in this case?
I did not.
Object form.
Why not?
They weren't important to my portion of the review, from my opinion.
Do you have them? Were they provided to you?
I'm not sure. I did get the entire medical record. So they could have very well been embedded in that.
Yes, ma'am. And I'm talking about something a little different now, policies and procedures. If you're familiar with policies and procedures?
Yes. Mhm.
And what is a policy and procedure?
It's a document that gives you guidelines for treatment.
Yes, ma'am. And those are guidelines for healthcare providers in the hospital, right?
Correct.
They're there for the safety of your patient, right?
Correct.
There's nothing more important than the safety of your patient, right?
Correct. Correct. And might I add that a lot of the policies and procedures, I won't say a lot, policies and procedures are grouped. So even though I order a medication on a protocol, the policy and procedure may be related to the nursing side of it, not necessarily my side of it, if that makes sense.
Yes, ma'am. You agree that policies and procedures are evidence-based
Yes,
and they're required to be followed
yes,
Object form.
to ensure your patient's safety?
yes.
And you performed the 4 T's
Yes.
test. About how many times have you performed that?
I would say Geez. I honestly can't quantitate. Um,
It's all
over
right.
my career, probably at least over 50, or at least 50,
50 times in 30 years.
yes.
And you agree that when you're performing the 4Ts, you have to start with a baseline platelet count?
Yes,
And you agree that that baseline platelet count is taken before uh, the initial heparin therapy?
Yeah, form. You can
You may answer.
I'm sorry. For clarification, do I agree that the baseline is taken before any heparin is given?
Yes.
I don't agree with that.
Okay. And cite for me any literature, again, any textbook, treatise, chapter in a textbook, peer-reviewed article, peer-reviewed article, grand rounds, throwaways, anything like that.
There's a article that involves cardiothoracic surgery patients in particular that suggests that you would take the baseline following surgery because of the immediate drop in platelets that's associated with cardiovascular procedures. This doesn't happen as much in my realm because I'm internal medicine and, not the procedures. But I have read the article that suggests that because there's a known drop, and we do see this even in people that have heart catheterizations, they drop their platelets, that you recalibrate them after the procedure, recalibrate and take their platelet count after the procedures.
And that becomes your baseline?
Yes.
And that article you were provided by your lawyers? Is that right?
No. Mm-mm.
Where did you get the article?
So when I read the deposition from Dr. Mayung, I went and did a little bit of additional research in that particular area, and I think I submitted it with my stuff.
That's an article that was Dr. Mayung brought to his deposition, right?
I can't recall if he brought it. I know he mentioned it. That's what made me go look a little further once I read his deposition.
Right. And you weren't provided the policies and procedures in this case, right?
Dr. Form, you can answer.
I'm not sure. I didn't look for them, honestly. I don't know if they're in my packet or not.
Okay, can you look and see?
I don't have it with me.
Where is it?
It is at home. Like, it's on my laptop, but I don't have it with me. Like, I don't have paper form of it. It was emailed, or it was a file, an electronic file.
And do you recall your notice of deposition? Did you review that?
I did.
And I'm going to go ahead and make that exhibit. I believe this is 40 your deposition. And you received that, but you didn't bring any documents with you to your deposition. Is that right?
Dr. Form, we produced them on her behalf.
You may answer.
No.
Okay. I'm going to show you what, I think this is number 5. We'll come back to this document. This is WellStar Policy and Procedure MU 7002. Do you see that?
I do. Mhm.
And this deals with direct thrombin inhibitor, DTI therapy. Do you see that?
I do.
And what is DTI?
direct thrombin inhibitor.
Okay, which is what? What is a direct thrombin inhibitor?
I'm looking at that. I'm not exactly sure what they're referring to.
Okay. Do you see here, the purpose is to define a process for the safe administration and monitoring of IV direct thrombin inhibitor patients? You see that?
Yes. Mhm.
Okay. And have you ever watched a cardiothoracic surgery or a cabbage procedure?
I did in med school, but not since then.
Okay, are you aware that the patient is given IV heparin in that
Oh, yeah.
procedure?
Yes.
Okay. And do you see where it reads PTT, a test used to monitor unfractionated heparin therapy?
Yes.
And do you agree that heparin therapy is a thrombin inhibitor?
Yes.
Okay. And thrombin inhibitor deals with clotting, right?
Yes. Thrombus. Yes.
Yes, ma'am. And you see the initial assessment here
Yes.
where it reads that caution document heparin as an allergy on the patient medical record, no heparin sign over patient's bed. Do you agree that if you suspect a patient has HIT or heparin-induced thrombocytopenia, that you document heparin as an allergy and place a no heparin sign over that patient's bed?
Not just with the suspicion, with confirmation.
Okay. So you would wait for confirmation from a HIT panel?
Yes.
Okay. And it goes under a caution, argatroban, you know what argatroban is?
Yes.
What is it?
It's another anticoagulant that is non-heparin.
It's a non-heparin anticoagulant, right?
Correct. Yes.
And do you know the type of heparin used in Billy Saunier's case?
It was unfractionated heparin.
Yes, ma'am. Do you know its origin?
Not sure what you're asking.
Porcine, it was from a pig,
Yes.
right?
Yes.
May cause an increased INR value when combined with other anticoagulant therapies such as warfarin. And what is warfarin?
It's Coumadin. It's another oral anticoagulant.
Yes, ma'am. You see over here on the left procedure
Yes.
and where it reads step 1.
Yes.
You see 1.1 draw baseline laboratory test prior to initiating therapy.
Yes.
And what is a baseline?
Are you speaking particularly for this protocol?
No, I'm just asking you what a baseline is.
So baseline, to my understanding, is prior to the onset of a certain therapy, you get a baseline number
Yes,
for
ma'am.
lab. Yes.
Right. And if you're talking about heparin therapy, it would be prior to initiating heparin therapy.
Fit form.
Yeah, I can't answer. I can't say that that's true. There's not, unless you tell me what particular lab you're talking about. Like
Well,
what
right
baseline.
now, we're looking at the policies and procedures to ensure patient safety at WellStar.
Correct. But this policy is for argatroban use, not heparin.
Actually, show me where you see that.
If you go down some,
Yes, ma'am.
right where you were before,
Uh-huh.
so it's talking about if you diagnose or suspect HIT there, this is the initiation of the argatroban.
Right, and part of it.
So they're asking.
Just
what-
about
they're
earlier,
telling
that
you to do
whether
this before-
to initiate argatroban, first you have to determine whether patient is suffering from HIT, right?
Correct.
I'm gonna object.
And this is, we're talking about the initial assessment here. Step one, draw a baseline laboratory test prior to initiating therapy. And now we're talking about prior to initiating therapy, right?
Therapy for argatroban.
Okay, so you're saying that this is only used, I'm not following you.
Yes, sir. So this, from what I'm reading of this policy is pertaining to the suspicion or the diagnosis of HIT and initiating argatroban therapy.
Right.
So drawing the baseline labs where your cursor is, drawing baseline labs prior to initiating argatroban would be the PT, INR, PTT, CBC, BMP, HEP panel, hepatic function panel, and HIT assay. Not prior to starting heparin, though.
And why would you tell me any literature that would suggest that before you determine a heparin baseline, the patient's already got heparin on board, other than that article you mentioned earlier?
Object form.
I don't understand your
that
question.
question.
Sure. You said that according to an article, it's a 2018 article, you don't take a patient's baseline heparin until you already administer heparin, right?
I think you misstated that because you said a baseline heparin before initiating heparin. I mean, typically before we start heparin, we do a CBC at minimum. But if you're talking about subcutaneous heparin, which is different from IV heparin, obviously, there's different monitoring systems for it. So the subcutaneous heparin that we use for DVT prophylaxis in most of our med-surg patients, they happen to have a CBC, but you would want to know what their platelet counts are before starting it, which is why they have the CBC, but it's not, I don't know that it's on a policy or procedure.
Well, you want to know their platelet count
And to make sure they're not anemic.
before starting heparin if you're going to assess how heparin impacted that patient's platelet count, right?
Correct. Yes.
Okay.
Excuse me.
It's all right. You're familiar with the sensitivity and specificity of a HIT antibody test?
Yes. So it's sensitive, but not very specific, which is why I was talking about the false positives. There's a significant amount of false positives associated with it. So there's a subsequent confirmatory test if you do test positive or get a HIT positive test.
In your 30 years, how many false positive HIT panels have you encountered?
Oof. That's hard to say. I'd say probably half of the HIT panels that we got were false positives.
Half were false positive.
Yeah, so like I said, for me, I've probably ordered 10 personally, so I would say 5 of those were false positives.
Okay. You understand that Billy Saunier died because he threw a clot in his bypass graft?
Yes,
Okay. And the clot in his bypass graft is what caused his death.
yes,
And you understand that heparin-induced thrombocytopenia causes clotting?
yes.
And that would include a clot in a bypass graft.
Object to the form.
It certainly could. My understanding and my experience, it's more systemic, meaning that it's not typically just isolated to one. Like you don't just see one clot. You may see a pulmonary embolus and a DVT. So certainly that could be encompassed in those, but it's not just typically not just one single clot.
And
Or
what
alternate clotting.
causes you to believe that was the only clot in Billy Saunier?
From the autopsy, that was the only one that was mentioned.
And you didn't speak to the pathologist?
No, I did not. I
Okay.
just read the autopsy from Kennestone and subsequently the medical examiner autopsy.
And do you know the diameter roughly of a cardiothoracic bypass graft?
I do not.
Okay, would you say it's large or small?
Object to the form.
I do not. It's not my area of expertise.
Well, do you agree that a coronary artery, its purpose is to supply oxygenated blood to the heart itself, right?
Yes.
And that it's on the outside of the heart,
Yes, sir.
not inside the heart?
That's correct.
And that's its sole purpose, right?
Yes, sir.
And so it's nothing remotely akin to the size of, the vessels leaving the heart, supplying oxygenated blood to the rest of the body, right?
Yes, I agree.
You agree you're not an expert in pharmacokinetics or pharmacodynamics of heparin?
Correct. Yes, I agree.
And you do not routinely manage patients on anticoagulation therapy?
Object to
I
the form.
disagree. I manage them all the time.
Okay.
Often.
Just not in a post-operative cabbage patient.
Yes,
Right.
sir, that's correct.
You agree ignoring or delaying critical actions during your patient's care can jeopardize your patient's safety
Yes,
and your patient's life ultimately?
yes,
You agree that heparin-induced thrombocytopenia is a life-threatening condition
I do.
and a patient can die from heparin-induced thrombocytopenia?
Yes, I agree.
And you agree that without prompt intervention, HIT can cause clots?
Yes,
Those clots can lead to organ failure,
yes,
including the heart.
yes,
The heart's an organ.
that's correct.
And as a result of the failure of the heart, a patient can die.
Yes, sir.
You agree that the standard of care requires immediate steps to prevent clot formation when HIT is suspected?
Again, I'd have to say that it depends on the probability.
Okay. And if it's intermediate to high, the standard of care requires immediate steps to prevent clot formation when HIT
Yes.
is suspected.
I agree.
You agree that policies and procedures are developed to guide healthcare providers in delivering safe and effective care to their patients?
Yeah.
Object to form, you can answer.
Yes,
And that would include physicians,
yes,
physician's assistants,
yes,
nurse practitioners,
yes,
and nurses.
yes,
You would agree that policies reflect best practices and evidence-based guidelines
yes,
for physicians,
yes,
physician's assistants,
yes,
nurse practitioners,
yes,
and nurses.
yes, sir.
You agree that ignoring policies can lead to preventable adverse outcomes,
Yes,
including death.
yes,
And I think you've already testified, you didn't review the policies and procedures in this case. And I think I asked you whether those were provided to you by your lawyers. And you said you don't recall. Is that right? You're
Object to
not
form.
sure.
I said that I'm unaware. I don't know if it's in that packet or not,
Okay,
in the packet that has the hospital records in it.
all right. You're aware that that this hospital, this facility had a policy for managing HIT,
Yes,
Object to form.
and that policy number is MU-70-02.
Object to form.
If you know.
I don't know.
Okay. You agree that the policies outline steps to follow when HIT is suspected?
I can't say that I do.
Okay,
I don't deny it, but I didn't see I'm not familiar with the policy.
yes, ma'am. So you can't answer any questions about the policies today?
Object to form.
I
You may-
can if they're shown to me, like the last one you just showed to me.
Okay. And are you prepared to give your full and final opinions today?
Yes,
You reviewed the medical records?
yes, sir.
I'm going to show you what's been previously marked as Exhibit 6. This is an excerpt. The medical records with the labs.
Okay.
You understand that and agree that Billy Saunier's baseline platelet count was 208?
Object to
I
form.
don't agree.
Okay. I'm showing you what's been previously marked as Exhibit 6. This is page 62 of that exhibit.
Yes,
We've got a lab review. You see where it reads platelet,
yes, sir.
and that's the platelet count, right?
Yes,
This is page 102 of Exhibit 6 to begin with.
Okay.
And it reads platelets, and you see where it reads lab results for last 7 days?
yes, sir.
And it reads 11, 14, 18. Do you see that?
Yes, sir.
November 14, 2018.
Yes,
Do you see that Billy Saunier's platelet count was 208?
yes,
And on November 16, it was 185.
yes, sir.
And do you recall his surgery was on November 19th?
Yes,
Now, still Exhibit 6, your deposition, page 132. Platelet counts from the last 7 days. You see 11/16, 18, November 16, 2018. Platelet count is 185.
Yes, sir.
And then on 11/19/18, that's the day of the surgery, right?
Yes,
His platelet count is 136.
yes,
And do you see that asterisk next to 136?
I do.
What's your understanding of the meaning of the asterisk?
If the platelet count is less than 150 typically, I'm trying to see if there's any different. Less than 150 would be considered thrombocytopenia.
Yes, ma'am. And then the following day, it falls to 120.
Yes, sir.
Same Exhibit 6, lower right corner, page 9. Platelet count from the last 7 days. You see on November 22nd, 2018, platelet count of 153.
Yes, sir.
The following day, 141.
Yes, sir.
The following day, 11/24/2019, 115.
Yes.
And same Exhibit 6, your deposition, lower right corner, page 13, results from the last 7 days. Platelet counts went from on November 23rd, 141, down to 115 the following day on the 24th, and down to 104 on the 25th. Do you see that?
Yes, sir.
Same Exhibit 6. This is, see lower right corner, page 6. You see that?
Yes.
This is November 25th, 2018. Do you remember what day that Billy Saunier died?
November 26th,
So this is the day before he died, right?
the evening before. Yes, sir.
And do you see where it reads cross cover note?
Yes, sir.
What is a cross cover note?
So if we're working in the hospital, typically there's a team of day doctors that are the primary providers. And then anywhere from late afternoon to overnight, there are additional staff, physicians or mid-levels that cover the service. So they write cross-cover notes if something happens to one of your patients. So they're not the primary on the case, but they are there and at bedside or available to respond.
And do you see this note, 2215, that's 10:15 at night, right?
Yes,
Notified by RN about this patient having 10-beat run of VTAC at 21:16. Do you see that?
yes, sir.
And do you know what VTAC is?
Yes, it's a
What is it?
accelerated ventricular rhythm, or when the ventricles are beating too fast.
And vital stable, orders given for EKG, check labs, potassium, magnesium and phosphate, ionized Ca, calcium, 2+ EKG, reviewed an EPIC NSR with RBBB. You see that?
Yes.
What does that mean?
Essentially, they ordered some labs that can be associated with ventricular arrhythmias or VTAC to see if they needed to be repleted. And then the EKG reviewed as normal sinus rhythm with a right bundle branch block.
You agree that a post-CABG VTAC can be a sign of a thrombus in the bypass ground?
Object to
I
form.
do not. I don't confirm or deny.
Okay. You don't know.
I don't know.
Okay. It goes on to read 2251, so that's 36 minutes later. Nurse reports he was reviewing a couple of days strips and noted slight ST elevation, stat troponin, CKMB, CK, no CO. Complaints of chest pain, will await results and may consider reconsulting cardiology. Do you see that?
Yes.
And that note's signed by Salome Maniari. Is that right?
Yes.
Hospital medicine.
Yes.
You see there's an NB or note below that, right?
Yes.
And that reads, I was never informed of any of the events mentioned above. This is a note signed the following day on an event that I was never made aware of.
Yes.
And what's the meaning of I was never informed of the above?
Object to form.
I can speculate in this case that the nurse practitioner or the she was a nurse practitioner that did the cross cover overnight, had to have they all have to have a co-signing MD, and so it must have gotten assigned to this MD, but they're saying that they weren't involved. Dr. Dodson was not involved, was not physically on site, and just was assigned the record to sign.
And is that something of a post, well, you don't care for post-CABG patients routinely, right?
Object to
No,
form.
but this sounds like it's hospital medicine, which that does occur, particularly in the change of service. So we do block scheduling. So if Dr. Dodson was just coming on and this patient was assigned to her, it could very well have been that it went to her box, even though she had not taken care of the patient.
If a post-CABG patient had a 10-beat run of VTAC, as a hospitalist, would you want to be made aware of that?
Yes.
Object to form.
And why is it that, and it would be imperative that you may be made aware of that, right?
Object to form.
It would be with the caveat that I would subsequently involve cardiology
Sure.
outside of doing what they did with the routine labs.
And why would you want to be made aware of that?
Excuse me, I didn't hear you.
Sure. And why is it that you would want to be made aware of that?
Because it may signal that there is something impending in regards to this patient.
And you want to do what you can to ensure the safety of your patient, right?
Correct.
And do you know what an ST elevation is?
Yes, sir.
What is it?
It's the ST segment is a part of the heart rhythm, and when it's elevated, it signifies that there's not good perfusion to a certain area, depending on where the ST elevation is, or not good blood flow to a certain area.
And an ST elevation post-CABG, you'd want to be made aware of that as well?
I agree with the caveat that you would need to know what the baseline EKG looked like. For example, some people have a chronic ST elevation, whether they're cardiothoracic surgeries or surgery patients or not. So it's really a change, an ST elevation that's new or a change.
Well, in order to determine that, you would have to know whether there was a post-op ST elevation, right?
Correct.
So if there was a ST elevation for 2 days, that's something you'd expect to be made aware of, right?
Object to form.
Yeah. I'd have to say that cardiology typically would be on board for that. And that would be under their preview. But again, as hospitalists, we're often the ones that are on site, particularly in the overnight hours. So it just kind of depends on the timing.
All right. Show you still exhibit 6. This is page 11.
Yes.
You see number 11?
Yes, sir.
This is a progress note by Saunier Camphor, MD, 11/24/2018 at 3:43 in the afternoon.
Okay.
So you see that, right?
Yes.
You've reviewed these records, right?
Yes, sir.
And it reads 11, sudden drop in the platelets from 141 to 115. Repeat labs in AM again if low order HIT, DWCTS, family aware of the drop in platelets. You see that?
Yes,
And
sir.
object to the form, you left out the discuss with cardiothoracic surgery, I believe.
What?
I object to the form.
Did I read that right?
I believe you read it
I'm
incorrectly.
not talking, these questions aren't for you.
I thought you were asking me for the basis of my objection. James,
No, you didn't. Go ahead. You may answer the question.
You're asking me, did I see this? I think that's the last thing I heard.
Well, I think I just, we went through this. I read it for the
Right.
record. Do you recall
Yes.
me doing that?
Yes, sir.
Did I read that accurately?
Yes, sir.
Is there anything in item 11 about cardiology?
No, cardiothoracic surgery, but not cardiology.
Okay. Well, show me where it reads cardiothoracic surgery, an
That's
item.
what CTS stands for.
Okay. And that's, I read that earlier, right?
Yes, you said CTS.
Okay. You see it reads sudden drop, 141 to 115. Do you see that?
Yes.
You agree that that is a sudden drop in platelets?
Yes.
Repeat labs in AM. Do you see that?
Yes.
And if low, order HIT.
Yes.
And by HIT, that's a hit panel, right?
Yes, that's my understanding.
And DW, CTS, and DW, is that discussed with?
Discussed with cardiothoracic surgery. Yes, sir.
Family aware of the drop in platelets. You see
Yes.
that? I couldn't hear you, and maybe I just didn't.
Yes, I did.
Yes.
Yes.
And that means you discuss this finding with the family of your patient, right?
Yes, sir.
And you agree that you discussed.
I'm sorry.
Sure.
Family aware of the drop in platelets doesn't necessarily mean that this physician made them aware. It could have been anybody on the care team, but just saying that they're aware.
Okay. But according to this physician's note, it was important that the family be made aware of this, right?
Yes, sir.
And you agree that if there are troubling issues with the patient after a cabbage procedure, you want to make the family aware of those, right?
Yes.
That's part of your job.
Yes, sir.
You see where it reads DVT prophylaxis, heparin, DVT, that's deep vein thrombosis, is that right?
Yes, sir.
And prophylaxis means it's a preventative measure, is that right?
Yes,
So Dr. Camphor also wrote DVT prophylaxis heparin, right?
yes,
In other words, the patient's getting heparin.
yes,
And you agree that as of November 24th, 2018, Dr. Camphor rightly has a suspicion of heparin-induced thrombocytopenia.
I disagree.
Okay. And you disagree because of why? Have you spoken to Dr. Camphor?
No, no, sir.
Right? Have you read her deposition?
Yes,
Okay, then why do you disagree that she suspected HIT on November 24, 2018 at 3:43 p.m.?
my interpretation of it is that they identify that there is thrombocytopenia, and that certainly HIT would be on the differential, among other things. But just reading the way, although there's some punctuation missing, the way it says, we'll repeat labs in the morning and then consider, if it's lower, then we'll consider HIT. I don't think there's, to me, it doesn't read that I think this patient has HIT today. I think it's in the differential, but that's just my interpretation.
Maybe I didn't do a good job with my question. A differential diagnosis or diagnoses is a list of potential diagnoses, right?
Correct.
And that list of differential diagnosis, your job as a physician, based on your training, is to rule out the diagnoses that it's not, right?
Correct.
And what you're left with, depending on the signs and symptoms, this constellation of signs and symptoms with your patient is the diagnosis, right?
Correct.
And what's on that differential diagnosis are diagnoses that you have not ruled out, right?
Yes.
In other words, those are suspected diagnoses that have not yet been ruled out.
I wouldn't say suspected, I'd say potential.
Okay, HIT was a potential diagnosis that has not yet been ruled out.
Yes, sir, that's correct.
And HIT as a potential diagnosis is a diagnosis that, unless you timely intervene, can kill your patient.
Yes.
So you want to best ensure the safety of your patient, do what you can to rule out heparin-induced thrombocytopenia as quickly as you can, right?
Yes. Yes, sir.
And you want to follow the policies and procedures for the hospital to do that.
Yes.
Now, still Exhibit 6 to your deposition. Do you see the lower right corner where it reads page 151?
Is that 15 or 151?
I apologize, 15.
Okay.
Lower right
Yes.
corner, page 15.
Yes, sir.
And do you see where it reads, I called, can you see my pointer there or this thing?
Yes, I can.
Okay. Reads, I move this.
James, before we get into this note, can we take a brief 5-minute break for a restroom break?
Sure.
Thank you.
And this is not to discuss the deposition with the witness.
Oh, no.
No, I need to use the restroom.
Okay, we'll see you shortly.
Thank you.
Yep. All ready to go?
Yes, sir.
Did you speak with anyone about your deposition over the course of the break?
No, sir.
Show you what's been marked as Exhibit 6 again. It reads here, this is still Dr. Campor's note. 11/25/2018 at 5:31 p.m., right?
Yes.
I called Dr. Klass, the hematology physician, who also agreed that the fall in the platelets are expected around day 5 of the surgery, and the fall in the platelets are not exactly 50%, but proceed with a HIT panel. You see that?
Yes.
And you agree that you would order a HIT panel if HIT was in your differential diagnosis?
Based on, it
Definitely.
depends on the probability. With the 4
If the
T
probability is intermediate or high, you would order a HIT panel.
Yes, sir.
And you agree that if you stop heparin, then HIT is part of your differential diagnosis.
Yes, sir.
And that if you stop heparin, you suspect HIT.
Objective form.
It would be in the differential. Yes, sir.
And you understand that Saunier Camphor, the hospitalist, stopped heparin, right?
Yes.
She did that on November 25th, 2018 at 5:31 p.m.
Yes, based on the documentation. I'm not exactly sure what time the order was placed.
We can look at the medication administration record. This is an abbreviated record,
Correct.
and we can see the order for that, right?
Yes.
Do you remember reviewing that order?
Yes. I don't
And
remember the exact time, but I did see the orders, the MAR.
do you remember the date?
I did. The date was the 25th.
Do you remember who ordered the heparin?
Order it to start or stop.
To start and to stop.
Believe the heparin order to start was by one of the cardiothoracic PAs,
Right.
and then the stop order was written by Dr. Camphor.
And was there also an order to stop a non-heparin anticoagulant?
Objective form.
To stop one, or I didn't hear you. To stop or start?
No, I said, I believe you just testified that it was Dr. Camphor that stopped the heparin, that ordered heparin be stopped, right?
Yes, sir.
Discontinued, same as stopped, right?
Yes, sir.
And when heparin was stopped, there was no order for non-heparin anticoagulant, right?
That's correct. Yes.
Now, have you had patients similar to Billy Saunier? Have you cared for patients similar to Billy Saunier?
Can you be more specific in regards to?
Sure. Post-cabbage patient, right?
Yes.
That has an intermediate to high score for probability of hit.
Objective form.
You may answer.
If being specific in those regards, if I may preface it by saying I don't think that he has intermediate to high probability from my perspective.
All right.
The answer would be no then.
Okay. No, you've not cared for patients in a situation like Billy Saunier.
Object to form.
Again, I disagree with the part of the statement in regards to the patients like Mr. Saunier that have a intermediate to high probability of having hit.
All
I
right,
have
you
taken
dis-
care of patients post-cabbage that there was a suspicion of hit.
Okay. And when you suspected hit, you would order a hit panel?
If the probability was intermediate to high, yes.
Okay, so first you would do the 4 Ts before you ordered a hit panel.
That's correct. Yes, sir.
And unless the 4 Ts scored intermediate or high, you wouldn't order a hit panel at all.
That's correct.
That was based on your policies and procedures?
It's based on my education.
Okay. Your education as a hospitalist and a pediatrician?
Yes, internal medicine training. Yes.
I'll refer you to page 20, lower right corner, still exhibit 6. This is the progress note by Delene Huff. This is Dr. Myung's PA, is that right?
Yes, sir.
And do you recall now the name of the PA that ordered the heparin according to the medication administration record, or MAR?
Yes, I believe it was Ms. Huff.
Object to form.
And you see here where it reads thrombocytopenia 104K, 115K, 141K, heparin on hold and hit sent. Is that right?
Yes.
And thrombocytopenia, I mean, the 104, 115, and 141 are actually the platelet counts. Is that right?
Yes, sir.
And based on those 3 platelet counts, according to this note, heparin was held, right?
Yes.
And a hit panel was ordered, right?
Yes, sir.
And according to the record, no non-heparin anticoagulant was administered, right?
Correct.
You agree that to hold heparin in a patient where heparin was ordered post-op to a cabbage and order a hit panel, that requires the provider to at least suspect heparin-induced thrombocytopenia.
Yes.
And to page 34, the same exhibit 6. These are progress notes by Delene Huff. This is November 24th at 11:57. Is that right?
Can you make that a little bigger or wider?
Sure.
Okay, thank you.
Sure. That's Delene Huff, PA,
Yes.
November 24th, 2018 at 11:57 a.m.
Yes, sir.
And you see here it's heparin, porcine, 5,000 units,
Yes.
subcutaneous,
Yes.
Q8H, it's Q8 hours, right?
Yes.
And that's under active medications.
Yes.
And the note at page 15. Actually, page 16. Dr. Camfor's note. 11/25/2018 at 5:31 p.m. Indicates that heparin was stopped due to low platelets.
Yes.
So what's been previously marked as Exhibit 7 to your deposition? We've already reviewed this. I mean, began reviewing it. This is policy and procedure. You hadn't reviewed this, right?
Not prior to today or earlier, no.
Did you review it over the course of the break?
No, sir.
Okay. So first time you've seen it that you recall, is that your deposition here today?
Yes, sir.
Okay. You agree that according to this policy, if a HIT assay is pending or a HIT panel is pending, the physician must still evaluate the patient's condition and decide whether to start a non-heparin anticoagulant, a DTI, right?
Object to the form.
I can't see that. There we go.
Well, you agree that this procedure, we went through step 1, draw a baseline laboratory test prior to initiating therapy. And in your view, that therapy, that's not heparin, that's argatroban, right?
Yes, sir.
And then 1.2, notify prescriber immediately of abnormal baseline laboratory results.
Yes.
1.3, evaluation of patient. Do you see that?
Yes, sir.
Check hit assay of heparin allergy not confirmed documented. You see that?
Yes.
And a hit assay, it's the same as a hit panel.
Yes, sir. That's correct.
And you agree that you can't check a hit assay or a hit panel if you haven't ordered and received the lab's findings on that hit assay or hit panel, right?
Back to form.
I'm not sure I understand the question.
Sure. This is talking about evaluating your patient. 1.3, this is page 3 of 5 of Exhibit 7. Do you see that?
Yes, sir.
And what you're doing is evaluating your patient to determine whether to administer a non-heparin anticoagulant, right?
Yes.
And it says here, check hit assay. Do you see that?
Yes.
And by check hit assay, that's the results of the assay, right?
Yes.
And when we say assay or panel, we're talking about the same thing, right?
My understanding, yes.
A hit lab, depending on how the lab handles it, right?
Correct.
Check hit assay. Without the hit assay, you can't check it, right?
Correct.
In other words, until you order it and get the workup back, you can't check it, right?
Correct.
Check hit assay if heparin allergy not confirmed documented. Calculate 4T score. Do you see that?
Yes.
Does that indicate to you that you order a hit assay before you calculate a 4T score?
It does not. I don't think there's any particular order. It's not like it says like 1, 2, 3. It just gives you the things to do or suggests the things to do.
So
Just as if you were to look at below on the right side where it says supplemental guidance, it just names, they're not even in alphabetical order. They're just different names of different anticoagulants.
what are you talking about here?
I was saying, I was making reference to if you go down to 1.4, the same where it says supplemental guidance, they just list multiple anticoagulants. They don't say this one first, this one second. I don't think that suggests that there's an order to do that in.
Doctor, are you in any way suggesting that you would administer Lovenox and Arixta
No,
and
not at all.
Eliquis? Let me finish the question. And Eliquis and Prodoxa and Xarelto at the same time?
No, not at all.
Okay. Are you suggesting in any way that you would administer those 5 drugs to the same patient at the same time?
Not at all. No.
What about any 4 of those drugs to the same patient at the same time?
No.
What about any
Well,
3
no,
of those
not
drugs, ma'am?
No, not 4. I'm sorry.
What about any 3 of those drugs to the same patient at the same time?
No.
What about any 2 of those drugs to the same patient at the same time?
Yes.
Okay, which 2 would you administer to the same patient at the same time?
We often bridge Lovenox and or heparin with the oral anticoagulants.
Right.
So you could get some overlap there.
And a bridge, what is a bridge?
A bridge suggests that, say, for example, if you're on a medication and we want to make sure we don't have any period of not being anticoagulated, there may be a time where you actually start a medication and then stop the other one once that one's in your system. So we call it bridging.
Right, and by bridging, you're going from one medication to another, right?
Yes, sir.
And for the safety of your patient, you don't drop one before starting the second, right?
Correct. Yes, sir.
You're not administering those drugs at the same time other than to go from drug 1 to drug 2, right?
Yes, sir.
And you're saying under 1.3 evaluation of a patient, it doesn't matter what order as far as whether you check a HIT assay or calculate a 4T or consider a Doppler ultrasound, the order doesn't matter. Is that what your testimony is?
Yes, sir.
Okay. And you agree, though, that you can't check a HIT assay if you don't have it,
Correct.
right? You agree that the HIT assay is only one evidence-based test for you to consider whether a patient's suffering from HIT, right?
Yes. It's
Okay.
only, it is the primary followed with the confirmatory test.
What's the primary?
So the HIT assay is the primary test to assess for it, and then it is confirmed by a secondary test due to the
What is the second? I apologize.
the serotonin assay. Serotonin, I think it's release assay, SRA.
Right.
Correct. So if the HIT does return positive, the next step would be to order that for confirmation.
But you're saying you don't order a HIT panel at all unless you score intermediate or high on the 4Ts. Is that right?
Yes,
Are you familiar with the American Society of Hematology, ASH?
I am. Mhm.
Okay. And have you studied any ASH guidelines?
I do believe one of the articles I submitted was from the ASH, I think.
The 2018 guidelines, is that what you're talking about?
I'd have to look at what I sent to make sure, but I can verify that.
You're welcome to do that, except you don't have those, right?
I don't. My attorney has, or Dr. Camphor's attorney has them.
Wait, say one more time, please.
I said they have them. I sent them here. I'm
Gotcha.
sure they could, yeah, I'm sure they could pull them for me.
You agree that according to the American Society of Hematology, that thrombosis can be asymptomatic in up to 50% of HIT cases?
Objective form.
I'm not aware of that.
Okay. First you've ever heard that was today?
In terms of the wording, yes,
Okay. You agree asymptomatic means without symptoms, right?
that's correct.
And if you've got, in half your HIT cases, if your patients can be asymptomatic or without symptoms, you would order tests. It would be imperative to order tests like a HIT assay, or Doppler ultrasound, or both, right?
Objective form.
In the setting, I just want to understand in the setting of
Sure.
HIT being in the differential diagnosis.
Yeah, I think we've already established that according to the medical records, it was in the differential diagnoses of the physicians caring for Billy Saunier, right?
Yes, sir.
And it would have been in your differential diagnosis too, right?
That's correct.
And until it's ruled out, it's there, right?
I don't agree with that.
Okay, are you looking at someone when you answer that question?
No,
Okay,
I'm looking, that's where you are on my screen.
okay. The I believe your testimony was that because of the 4Ts, you would have ruled out heparin-induced thrombocytopenia and Billy Saunier, right?
I would not have performed the HIT test was my testimony.
Okay. And no one in this case fell below the standard of care, right?
Not in my opinion, no.
Okay. Can you cite for me any treatise, textbook, chapter in a textbook, peer-reviewed article, non-peer-reviewed article, throwaways that suggest you don't order a hit assay unless until after you calculate the 4 T's and until after the 4 T's say you've got an intermediate to high probability of hit. Is that right?
That's correct. I don't have a specific site. That's the way we were trained.
All right. That's the way you did it in your the hospital in Missouri, right?
Yes,
You familiar with the American College of Chest Physicians?
I am.
Okay. Are you familiar with their guidelines regarding heparin-induced thrombocytopenia?
I can't say that I am.
You agree that if you're caring for a patient where HIT is in your differential diagnosis, that you have to be vigilant?
Yes,
And even in the absence of symptoms due to the high incidence of asymptomatic thrombosis, you have to be alert for HIT, heparin-induced thrombocytopenia.
yes,
And that's to, as best you can, ensure the safety of your patient.
yes, sir.
Now you see over in the right corner, page 3 of 6, still exhibit 7 of your deposition.
Yes, sir.
This is still the procedure, the initial assessment. See page 2 of 5. Now we're at the initiation and administration of infusions. You see that?
Yes, sir.
And specify 2.1 specify which initial dose to use.
Yes.
And this is the non-heparin anticoagulant, right? For
Yes,
instance,
sir.
Atraban, right? Document weight for bivalirudin. Separate, calculate initial bolus dose based on actual patient weight. Verify calculations, consult primary or pharmacy to initiate monitor therapy and order necessary labs. You see that?
Yes.
Step 3, do you see that?
Yes, sir.
Obtain PTT level after initiation of therapy therapy per order DTI. So you
Yes.
monitor it, right?
Yes, sir.
3.3, do you see that?
Yes, sir.
Repeat PTT, and what's a PTT?
Partial thrombin time.
After each dosage adjustment until a therapeutic level is achieved. In other words, you have to monitor these drugs as well.
Yes, sir.
Transition to oral anticoagulation, e.g. warfarin from argatroban. This is once you deal with the HIT, right?
Yes, sir.
And none of those things were done because no non-heparin anticoagulant was ordered or administered, right?
I agree.
You agree HIT is a prothrombolytic condition, meaning clots can form rapidly,
Yes, sir.
and they can form rapidly even without clinical signs.
Yes.
A Doppler ultrasound of the legs is commonly performed to detect DVT, right?
Yes,
As untreated DVTs can embolize to the lungs, pulmonary embolism,
that's correct.
causing life-threatening complications.
Yes,
And they can embolize to other parts of the body,
yes.
including a bypass graft.
Not the DVT, but clots can form there. That's the venous system. So a DVT in the lower extremity would only go to the venous system, not to the arterial system.
But, and thank you, a clot can, if you've got a clot, it can go to places other than the lungs, right?
Yes, sir. That's correct.
And that would include the heart.
Yes, sir.
That would include the vessels that supply oxygenated blood to the heart,
Yes, sir.
and would include a bypass graft.
Yes, sir.
You agree that the clinical team in Billy Saunier's case suspected HIT?
Back to the
I
form.
do agree that it was on their differential diagnosis. Yes.
That was indicated by the platelet drop, their notes, and their lab orders, right?
Yes, sir.
And no Doppler was ordered.
No.
And the HIT testing was ordered as a result of Mr. Saunier's platelet count being noted to drop progressively more each day, right?
Yes, sir.
Okay. You agree that an ST elevation 5 days post-op and a cabbage surgery can be a sign of a graft thrombosis? Right.
That form.
Again,
If you
I
know.
have to know the baseline or the previous EKGs, like post-operatively.
Well, how would that, if you've got an elevated ST, why would it matter how elevated it is in a post-cabbage patient?
Not necessarily how elevated it is, but if it's a change. In other words, if he has a baseline mildly elevated ST segment, and that goes from mild to, more increased elevation, then that would certainly be significant. If it's the same as it was immediately post-op, then it doesn't hold as much weight, in my opinion.
Well, if it's the same, that's not equal to elevated, right? Elevated indicates a change.
No,
Okay. So you're saying if someone said we've got a post-op elevated ST, what they could be saying is we've got a post-op elevated ST, but it was elevated before anyway.
correct.
Okay. Have
Like
you ever
you'll see some documentation that says patient has a chronic ST elevation. So if it hasn't changed from that level, then it's ST elevation, but it's not significant.
Did you see anything in Mr. Saunier's medical records that suggested he had a chronic ST elevation prior to his cabbage surgery?
I did not.
You agree that once HIT is suspected and heparin is stopped, anticoagulation with a non-heparin agent is strongly considered to prevent thrombotic events while awaiting confirmation.
If it's intermediate or high probability, yes, sir.
Okay. So if you agree, if the 4 T's is intermediate or high,
Yes, sir.
and otherwise no.
Yes, that's correct. Otherwise, no.
You agree that that policy supports initiating a non-heparin anticoagulant like argatroban before lab results return if HIT is suspected and the clinical picture warrants it.
Object form.
Again, in my experience, if it's intermediate or high probability, yes.
Okay. Intermediate or high probability, you're talking about the 4 Ts,
Yes, sir.
would warrant it, right?
Yes, sir.
And did you compute Mr. Saunier's 4 Ts?
I did.
And did you see a computation for Billy Saunier anywhere in his medical record?
Not that I recall.
Okay. Well, do you think you'd recall it if it was there?
I do.
Okay. It wasn't there, right? Is that right?
It wasn't there. I don't,
Okay.
I did not see it.
And you agree that when HIT is in your differential diagnosis, you're required to do a 4T score for your patient, right?
I think it's the standard of care to calculate one.
Right. But none was calculated in his medical record, right?
There was none documented in his medical record, no, sir.
Have you ever heard the phrase "not documented" means not done?
I have.
And of course, you're caring for a patient, so you don't document every little thing, right?
That's correct.
But if you've got a patient where you suspect and HIT is part of your differential diagnosis, and there's a test, a 4T score you can do to, potentially rule out or confirm your clinical suspicion, that needs to be documented, right?
Yeah, to the form.
In my opinion, the verbiage of stating that it's low probability can be an inference that they calculated the score and it was low probability. Because the score is a range, so they didn't necessarily say his 4T score was 2, 3, 4. They said it was low. They said he had low probability of HIT.
And so you made an inference based on the phrase low probability.
That's correct.
You inferred that they computed Billy Saunier's 4T score. It just wasn't documented anywhere.
That's correct.
And your score was what?
3.
3. And you agree that any score over 3 is an intermediate probability, right?
No, sir. It's 4.
4 or more?
4 to, I believe it's 4 to 6, 4 to 0 to 3, 4 to 5, and then 6 to 8 would be the categories.
Right. 0 to 3 is low, right?
Low probability. Yes, sir.
4 to
I believe it's 4 to 5.
6.
Is it?
6 to 8. Yeah. 4 to 5, 6 to 8, right?
Yes, sir. Mhm.
So anything over 3, of course, 4 being over 3, right?
Yes, sir.
Anything over 3 is an intermediate probability
Yes, sir.
that would require ordering a HIT panel
Yes, sir.
and would require a clinical determination about whether to start a non-heparin anticoagulant.
I agree.
Okay. And assuming your baseline, you use the baseline, you didn't use 208, right?
Yes, sir.
And you didn't use 208 because of the article in Mr. Young's deposition. Is that right?
Yes, sir.
And you've made this computation, not a lot, but you've made it a handful of times in your own practice, right? Can you see me? Sorry.
It is getting darker. Yes. Yes.
And when you computed the baseline in those cases, you would wait until after the surgery, after the patient had already had heparin, already had a bolus of heparin, before you would determine the baseline. Is that right?
Yes, sir.
Okay. And you did that based on your education, training, and experience.
Yes, sir.
Okay. Show you what I think, is this number 8, Madam Court Reporter?
Yes.
Thank you. Show you what's been previously marked as Exhibit 8 to your deposition. And have you ever seen this document before?
I have not before now.
It reads subcutaneous anticoagulation monitoring and management. Do you see that?
Yes,
And you agree that Billy Saunier, while he was an inpatient at WellStar's Keystone Hospital in November of 2018, was receiving subcutaneous anticoagulation monitoring and management.
yes,
And he also received IV heparin, right?
that's correct.
And that was during his cabbage procedure, surgery, right?
Yes, and doing his heart cath, if I'm not mistaken.
Yeah. Do you remember what day his heart cath was?
The 15th, November 15th.
And you agree his heart cath on November 15th, when he also had heparin therapy, that would make him more likely rather than less likely after this second procedure, the same month, to be susceptible to hit, right?
I don't agree with that.
Okay, and that's based on what?
I don't know that from my understanding, HIT is somewhat of for lack of a better word, an autoimmune. So it's an antibody that's produced against HIT. I don't know that it has to do with, how am I trying to say this? I don't think that it necessarily has to do with how much heparin you get. I think some people are susceptible to it and others are not. There are some people get that same amount of heparin and not have HIT at all or any consideration for HIT.
Are you aware that if you had a PIC, you agree that's a PIC procedure?
A PIC?
Check to form.
Not a PIC. Do you agree that if that there are peer-reviewed articles that suggest that if you have had another heparin administration or therapy within that time frame, that would double your likelihood of heparin-induced thrombocytopenia?
No, I'm not. I mean, I haven't come across that.
Okay. So, see where it reads ordering and monitoring.
Yes, sir.
You see, WellStar Health System, the prescriber's initial order, subcutaneous anticoagulation, and you agree that heparin is an anticoagulant,
I do.
and that it was administered subcutaneously, which means under the skin, right?
Yes, but this protocol is talking about low molecular weight heparin, not the porcine heparin, just FYI.
Well, I don't see where does this
Where
say?
it says where it says LMWH, they're talking about Lovenox. This policy.
Go ahead, I apologize.
This policy is talking about Lovenox as opposed to heparin.
Do you see where it reads with LMWH, which that's low molecular weight heparin, right?
Yes, sir.
Or factor XA inhibitor.
Yes, sir.
Therapy will initiate the following procedure. You're saying this only applies to low molecular weight heparin?
Yes.
What is the difference in a factor XA inhibitor and low molecular weight heparin?
It's not, the factor XA inhibitor is not, does not contain heparin, from what I understand. I don't use that very often at all.
See where it reads subcutaneous anticoagulation therapy?
Yes, sir.
Includes LMWH and factor XA inhibitors.
Okay. I see that.
So are you still suggesting that this doesn't apply to the heparin administered to Billy Saunier November 2018?
I'll agree with you that it does. It's not worded great, but I'll agree with you that it does, because it down below it just keeps talking about the Lovenox and the factor XA inhibitor.
No, so I can agree with you that it's not worded great. How about that?
Okay, we're in agreement.
Yeah, well, on some stuff. Pharmacists will verify the dose based on the patient's indications, weight, renal function.
Yes.
What are necessary baseline labs to verify dose per renal function, anemia, thrombocytopenia, right?
Yes, sir.
And in your view, a baseline lab would be for Billy Saunier after he'd already had a bolus plus of heparin in his cabbage surgery, right?
Yes.
This initiate procedure MU 70-04, you didn't look at that either?
No, sir.
Oh, Heather, why weren't we provided with MU 70-04?
I'm sorry.
Why weren't we provided with policy and procedure MU 70-04?
When? When are you talking about?
That's okay.
I believe this was provided to you in discovery years ago.
Including the MU 70?
I believe so. How
Okay.
else do you have it?
Well, we've got 2 and 4 and 3. We don't have MU 70-04.
I'm not following you, James.
That's fine. I'll ask you about it. Thank you. You see where it reads adjust dose per patient's indication?
Yes.
Provide education to all patients. C 1.6, notify the prescriber if the patient develops signs or symptoms of active bleeding or thrombosis.
Excuse me.
Yes,
And by active bleeding, that would include something like a nosebleed,
yes, sir.
bleeding of gums,
Yes,
bruising,
yes.
bruising at surgical sites.
I wouldn't say that specifically. That's kind of an expected
Okay.
finding post-op.
Have you ever had a patient that had an abdominal bruise the size of a basketball after a cabbage?
Not particularly after a cabbage, but I have had patients with extensive abdominal bruising on subcutaneous heparin.
Okay. And that
That's
is a
the injection
potential
site.
sign or symptom of what?
The bruising is typically it's at the injection site from the heparin, the one that I'm referring to. So
Right.
you get extensive bruising at the injection sites due to the heparin being an anticoagulant or blood thinner.
Right, and it's a potential sign or symptom of HIT, right?
No, sir. Bruising, no, sir.
Bruising is not, you're
No,
saying.
sir.
Okay. So why would you notify the provider of bruising?
In regards to this policy,
Yes, ma'am.
there's a potential I would discontinue the heparin, or either consider another form of anticoagulation because the heparin injections are so frequent, every 8 hours, so they're getting multiple sticks into the subcutaneous area. So I would switch to Lovenox, which is once a day, or even ascertain if they really still needed, like if they're up and ambulating, I may say they don't need DVT prophylaxis.
But it would not create a concern for you about the potential for heparin-induced thrombocytopenia, right?
No, sir.
Okay.
Not just the bruising itself, no.
Well, I didn't say just bruising. Same for blood in the stool. That's not a potential sign or symptom of heparin-induced thrombocytopenia in a patient that's being administered heparin.
The best way to answer that would be in and of itself, I would say no. You could get clotting to the mesenteric arteries, but that's typically extremely painful. So it's not just blood in the stool, it's abdominal pain, severe abdominal pain, and rectal bleeding.
I don't see any just here. I'm talking about whether these are potential signs or symptoms of heparin-induced thrombocytopenia.
Okay,
And if you say they're not, then, bruising is not a potential sign or symptom of HIT,
it
right?
is not.
Blood in the stool is not a potential sign or symptom of HIT.
It is not.
Urine, blood in the urine is not a potential sign or symptom of HIT.
No,
Blood in the sputum or gums is not a potential sign or symptom of HIT.
no,
Gastrointestinal bleeding is not a potential sign or symptom of HIT.
no,
Spontaneous bleeding is not a potential sign or symptom of HIT.
no,
Changes in level of consciousness, not a potential sign or symptom of HIT.
it could be.
Okay. Thrombosis, not a potential sign or symptom of HIT.
It is a sign of HIT.
Okay. And signs or symptoms of thrombosis would include redness.
Get to the form.
The answer.
No,
Warmth,
no,
tenderness,
yes,
swelling, edema
yes,
in the extremities,
yes,
sudden shortness of breath or chest pain,
yes,
and altered mental status.
yes, potentially.
Do you remember what Billy Saunier's hemoglobin?
The lowest I saw it was 9.2, I believe. He started around 14 and dropped to 9.2 and then started to come back up.
Okay. You agree with 1.8, notify the prescriber if the patient has an allergy to the ordered subcutaneous anticoagulant, right?
Yes.
And in order to determine whether your patient had an allergy to the heparin, you would do what?
I think they're talking about by history here. If the patient has a known history of allergy. So that would have been on a prior occurrence, prior presentation that they were deemed allergic to heparin or allergic to an anticoagulant.
So, well, you wouldn't start the heparin. I mean, you wouldn't start heparin if the patient had a known allergy, right?
Correct. But oftentimes we'll order something and it's not necessarily listed, and the pharmacist will call and say that, you know, the patient's care everywhere says they're allergic to amoxicillin. Because the pharmacist does a little, like whenever we order medicines, they do a more detailed review. And so sometimes they're not listed. And then sometimes it just doesn't flag you that they're listed. Like you'll put in, oftentimes when you put in an order in the electronic medical record, it'll tell you, like when you go to hit sign to send it, it'll say, you know, this is contraindicated, patient has an allergy to this medicine or one in the class, but it doesn't, they're not always in the chart like that. So sometimes the pharmacist will alert us that the patient is allergic to it, or we'll order it and the nurse goes to take it in and the patient says, is that heparin? I can't take that. They told me never to take it again.
Do you agree that coughing is a potential sign or symptom of HIT?
I do not.
Chest pain,
I do not.
rapid heartbeat,
No.
skin changes,
Yes.
fever and chills,
No.
dizziness,
No.
weakness.
Yes.
And see where, let's see, step one continued. Now we're on page 3 of 3.
Okay.
You see where it reads required action steps?
Yes.
Discontinued treatment or prophylactic dose used as bridge therapy once INR is within therapeutic range. This is just talking about going from heparin to warfarin, right?
Yes.
All right, it's 12:30. I'm going to have to take a lunch break. We'll start back at 1:30. How's that?
Okay.
All right. What's that?
Yes.
Oh, I heard you. I didn't know if Heather said something.
Yeah, I said, ready to roll.
All right, thank you. We on the record, Madam Court Reporter?
Yes.
Show you what's been previously marked as Exhibit 9 to your deposition. This is the continuous IV heparin therapy procedure. And this is the heparin that Billy Saunier received over the course of his surgery, right? The cabbage,
Yes.
CBG. And you hadn't seen this before today either, is that right?
No, sir. That's correct.
Okay. It reads continuous IV heparin therapy procedure. It's policy procedure number MU 70-01. Do you see that?
Yes,
Effective March 2018. Right.
yes,
And this was effective in November 2018 when Billy Saunier was a patient at WellStar's Keystone Hospital.
yes,
And the purpose, you see this, is to define a process for the safe administration and monitoring of IV heparin in patients 18 years of age or older. Do you see that?
yes, sir.
And of course, Billy Saunier's over 18, according to the record.
Yes,
Yes, and he was receiving heparin, both IV and subcutaneous, right?
Object to the form.
throughout his stay, yes.
Yes, ma'am. And it reads here definitions. And an anti-factor or XA or an anti-XA, you're familiar with that?
Yes,
And it's a lab test used to monitor unfractionated heparin therapy, right?
yes, that's correct.
And that's what Billy Saunier was receiving, unfractionated heparin.
Object to form when?
You may answer.
Object
Yes.
to form.
Yes, during the IV therapy, yes.
Yes, ma'am. And we're talking from the 19th through till the 26th, when Billy Saunier died, he received heparin both IV on the 19th and subcutaneous from the surgery until his death on the 26th, right?
Until the 25th, yes, sir.
25th or 26th?
They stopped it on the 25th?
Yeah, and he died on the 26th,
Yes.
right? And it reads here, HIT, heparin-induced thrombocytopenia. Do you agree that HIT means heparin-induced thrombocytopenia?
I do.
With or without thrombosis, and a thrombosis is what?
A clot,
A blood clot.
yes, sir.
And it reads marked by greater than or equal to 50% decline. Do you see that?
Yes,
In platelets,
yes, sir.
typically seen within 4 to 10 days of heparin exposure. You see that?
Yes,
And Billy Saunier's decline was even before 4 days, but within 4 to 10 days of his heparin exposure, right?
he actually had a decline and then a rise and then another decline. So that would be yes with that caveat.
Patients with confirmed HIT should not be administered heparin. You agree with that, right?
Yes,
And the way to confirm HIT is with a HIT panel or a HIT assay.
yes, sir.
Any other way that you're aware of?
No,
Then it goes on, actually PE, that's a pulmonary embolus. And what is a pulmonary embolus?
a blood clot to the lungs.
Yes, ma'am. And PT, prothrombin time, what is that?
That's a lab test for anticoagulation or yeah, to assess for anticoagulation.
And how does it assess for anticoagulation?
The pro time is coexist with the INR, and it tells you that there's a reference range of blood thinning, so you'd want it to be in a certain range to know that the blood is appropriately thin when you're anticoagulating somebody.
When you see here where it reads procedure,
Yes,
and then it's got required action steps, who performs them, and any supplemental guidance. You see that? Those are the 3 columns.
yes,
And you see here initial assessment.
yes,
There was something similar in the earlier policies and procedures we watched, right? Or
Yes.
walked through. See, 1.1, obtain baseline laboratory tests prior to initiating heparin. Do you see that?
I do.
And we talked about a baseline earlier, right?
Yes.
And according to this policy, the baseline is obtained prior to initiating heparin, right?
Yes.
And so the baseline for Billy Saunier occurred before the surgery on the 19th, right?
There was a baseline before the surgery on the 19th. Yes.
Right. And is it your testimony today that you use a different baseline for administering heparin than the baseline you use for determining whether that patient is suffering from HIT?
Yes.
Okay. And you got that from that article, is that right?
Yes.
The one that Mr. Mayung used in his deposition?
The doctor.
Dr.
Correct.
Mayung?
Yes.
Okay. Any other treatise, textbook, chapter in a textbook, peer-reviewed article, non-peer-reviewed article, grand rounds, throwaways, in the history of your 30 or so years practicing medicine, that suggests that you use one baseline to administer heparin and another baseline to determine whether that same patient is suffering from heparin-induced thrombocytopenia?
No, other than the article that was stated, no, sir.
You know, that one article, right?
Yes.
And actually it's one line, one paragraph, one line at the end of a paragraph on page 2 of the article, right?
Check the form, you can answer.
Yes.
Yes. Yeah. Anything else?
No.
Okay. Now, of course, the baseline is defined by the WellStar policy and procedure is the baseline. We can all see this, right? Prior to initiating heparin, right?
Yes.
Object to the form.
And on to page 2 of 7, note, heparin therapy may be initiated prior to the receipt of baseline laboratory results unless otherwise directed by the prescriber. And what that means is after you submit the blood to get the baseline, you can go ahead and start the heparin before you get the baseline back, right?
That's my understanding. Yes.
Yeah. And one reason that would be the case is because this patient's not already on heparin. So it's going to give you a baseline, which is a reference point for later computations. Computations, let's say, to determine whether that same patient from that same drug is having a reaction to the drug known as heparin-induced thrombocytopenia.
It could be. Typically, I get the more common thing is actually heparin and the CBC for the red cell count to make sure they're not having any bleeding complications or their hemoglobin is not dropping. And then heparin in and of itself will drop the platelets even without HIT. So we're monitoring for including HIT, those other things.
Right, which is another reason to consider a baseline other than the one after you've already given the patient heparin, right?
Can you repeat that? I'm sorry.
Would you read it back, please, Madam Court Reporter?
Which is another reason to consider baseline other than the one after you've already given the patient heparin, right?
Yes.
Now here, 1.4, this is page 2 of 7. This is exhibit 9. Is that right, Madam Court Reporter?
Correct.
Thank you. Review baseline labs, notify prescriber of abnormal lab results. Note, if platelets are between 50 and 100 or greater than 50% decline seen, notify physician. Continue to administer heparin unless new orders are received from physician or if signs of bleeding noted. Do you see that?
Yes.
So even if it's greater than 100, if you see signs of bleeding, you need to DC the heparin. Is that right?
No, it says notify the physician and continue the heparin unless the physician says otherwise.
Unless new orders are received from physician or, you see this or here? or if signs of bleeding noted, right?
Gotcha. Yes,
And this is something you weren't shown before today's deposition, is that right?
I did not review this, no.
Well, do you recall the lawyers in this case handing you anything that looked like this?
No, again, like I stated before, it's not, I can't say that it was not included in my packet from the with the medical records in there.
Nor can you say it was included in your packet, right?
Correct. Correct.
Subcutaneous heparin or other parenteral anticoagulation, oral anticoagulants. We've been through this, right?
Yes.
Other policy. Initiation and administration of infusion. We scroll down to 2.5. Continue monitoring of infusion. You agree that heparin requires monitoring?
Yes.
And page 3 of 7, still exhibit 9. At any time during the infusion, discontinue the heparin infusion immediately and alert the prescriber if the patient experiences adverse effects such as change in level of consciousness or headache, right?
Yes.
You agree that a headache or change in level of consciousness are potentially adverse effects of heparin? And if you don't, that's fine too.
No.
Okay. Bleeding is evidenced by bruising, evidence of blood in the stool, urine, sputum, and or gums, gastrointestinal bleeding, prolonged or spontaneous bleeding from an intravascular access site, hypersensitivity reaction. Do you agree that those are potential signs and symptoms of heparin-induced thrombocytopenia?
Check to the form.
No.
I'm
I'm sorry. Yeah, I thought you were still just talking about heparin administration. So to be clear, if you're saying, are these signs of HIT? I say no.
Okay. And what are they potentially signs or symptoms of?
Excessive bleeding from anticoagulation.
Okay. And do you agree that excessive bleeding can be a sign or symptom of heparin-induced thrombocytopenia?
No.
Okay. 3.1, obtain anti-XA level. What is an anti-XA? We talked about that, right? It's an assay to determine whether you're in a required therapeutic range of the heparin, right?
That's correct. Yes.
Anti-XA level 6 hours after the initiation of IV heparin therapy, and then follow instructions including the heparin dose adjustment nomogram. You see that?
Yes.
In other words, there's, as part of the order sheet, there are therapeutic ranges for the different types of heparin, right?
Yes.
And if a provider sees that that patient is outside that therapeutic range, they're to take appropriate actions, right?
That's correct. And
And
just to
did
be
you see?
clear,
I apologize.
sorry, sir. Just to be clear, the heparin is the same. The range of anticoagulation depends on what you're treating.
All right. Also depends on what type of heparin you're using. It would be different for low molecular weight heparin, right?
We don't heparin IV. I'm sorry. Yeah, the heparin IV heparin is the only one that we do the monitoring for with labs. The Lovenox is weight based, and it is what it is. We don't check any like labs to see if it's therapeutic because it's weight based.
All right. And use the anti-XA, and some people say anti-10A. I'd say XA. You can use whatever you prefer. You have a preference?
X is fine.
Okay. Use anti-XA level to adjust heparin infusion doses per the heparin dose nomogram. My question is, did you see any anti-XA level in the medical record for Billy Saunier?
I did not.
Obtain anti-XA level daily once the desired anti-XA value is achieved. Again, none of those in the record, right?
I did not.
Yeah. To assess 3.10, this is page 5 of 7. Assess vital signs and signs of bleeding every 8 hours during IV heparin therapy. You see that?
Yes.
And you agree that the standard of care requires that?
Yes.
Supplemental guidance over here in the third column again. Assessment includes headache. Do you agree that a headache is a potential sign or symptom of HIT?
I do not.
Changes in level of consciousness,
No.
hematuria.
No.
What is hematuria?
Blood in the urine.
Um, hemoptysis,
Hemoptysis. Yes, potentially.
hemoptysis.
Yes, sir.
Is that a sign or symptom of HIT?
Yes, potentially.
Hematemesis,
No.
melena,
No.
Terry stools.
No.
Terry stools can indicate blood in the stool, right?
Yes, sir. That's correct.
Were you aware that you recall reading Mr. Saunier's wife's deposition, Kathy Saunier?
I do.
Do you recall her testifying that after surgery, while he was still inpatient, he had bloody stools?
I do. Yes, sir.
He also was coughing
Yes.
and that he had bleeding and bruising?
Yes. Nosebleeds and bruising on the
And you
abdomen at the
can-
surgical site.
I apologize, I didn't mean to. Yeah, do you consider any of those to be potential signs or symptoms of heparin-induced thrombocytopenia?
I do not.
Okay. Petechia,
Petechiae? No, sir.
petechiae, bruising,
No.
nosebleeds.
No.
This is assess vital signs and signs of bleeding every 8 hours. This looks to me like the same. 310 and let's see, 3.10 and 3.2 look the same to you.
Yes.
Okay. Show you what has previously been marked as the Exhibit 10 to your deposition. Exhibit 10, these are labs, a laboratory report that includes Billy Lee Saunier's heparin panel, right?
Yes.
And here it is on page 2, is that right?
Yes, sir.
And there's a reference number here, X13726113. That's just a collection lab number, right?
Yes, sir.
And COLL, that stands for collection or collected.
Collected. Yes.
So this blood, was it blood?
Yes.
Was collected on 11/25/2018 at 11:20, right?
Yes.
And it was received on 11/25/2018 at 12:02.
Yes.
And and the physician, Richard Mayung, he was a cardiothoracic surgeon, right?
Correct.
That did the cabbage. Yep. And it reads heparin-induced thrombo AB or antibody, is that right?
Yes, sir.
And that's also called a HIT antibody.
Yes,
And the order was, you see that stat?
I do.
And what does stat mean?
With urgency, top
Okay.
priority.
Right. And you know, if you suspected HIT, you would order a HIT panel stat or high priority, right?
Yes, sir.
And that's what was ordered here, right?
Yes,
And then you see where it reads present, heparin-induced thrombocytopenia antibody present, right? So the HIT antibody is present,
yes,
which indicates heparin-induced thrombocytopenia, HIT, right?
yes,
And it reads here, patient expired, which means sadly Billy Saunier had already died.
correct.
Called to Barbara RN at 23:10. Now that's at 11:10 at night on November 26, 2018, right?
Yes,
And that optical density, and you see that capital H there? What does
do.
that indicate?
High.
All right. And you see the 0.000 to 0.399. That's a normal range, right?
Yes,
And 3.399 is high normal, right?
yes, sir.
Anything higher than that is abnormal or high. Is that right?
Correct.
And you see 0.399, do you see his score, the high was 3.501, right?
Yes,
And that's nearly 9 times the high normal.
yes.
Do you recall ever getting a HIT panel that was 3.501 or 9 times the high normal?
Not to my recollection, no, sir.
Okay. You agree that's indicative of Billy Saunier suffering from heparin-induced thrombocytopenia, right? According to the,
I believe it's highly suggestive, but would still warrant the confirmatory test.
well, and you can't do a confirmatory test on a dead man, right?
That's correct.
That's why you want to get, you need to intervene early such that, you know, this is useful information. It's not useful to a healthcare provider if the patient's already dead, right?
I agree.
Okay. Do you remember the highest you've ever seen a HIT panel?
I think the highest I personally had is a 2.9.
That's pretty high.
Yeah.
And
We did the confirmation that person did have HIT. Yes. They were
And-
med surge, not post-op patient.
say again, please.
Medical surge, med surge patient, not post-op. Mhm.
That patient survived.
They did.
And did you discontinue the heparin and start a non-heparin anticoagulant?
The hematologist did, yes. Our care team did, yes. We actually can't write for the argatroban
Okay. You have to be a hematologist.
at our facilities, yes.
Okay. I'll show you what's been previously marked as, I think this is 11. Is that right, Madam Court Reporter?
Yes.
Thank you. Show you what's been previously marked as Exhibit 11 to your deposition. Have you ever seen this document before?
Yes,
Billy Lee Saunier's autopsy.
yes,
And do you see final pathological diagnoses? You see that?
yes, sir.
History of acute post-operative respiratory insufficiency. Do you see that?
Yes.
And what is acute post-operative respiratory insufficiency?
That would be following his surgery. He had difficulty with either oxygenating or breathing comfortably such that he needed supplemental oxygen.
And do you see here aspirated organized blood clot within bronchus of to lower lobe of left lung? Do you see that?
Yes.
And we've already discussed that heparin-induced thrombocytopenia or HIT can cause blood clots.
I agree with that, but this blood clot in the lungs is not in the blood vessels, so it's not the same thing. It's not a thrombus.
Okay, so you don't, it's your view that this clot could not have been caused by HIT, right?
Correct.
And then and you see here at page 7, summary and interpretation.
Yes.
You see where the autopsy findings are significant for an inclusion of the coronary artery bypass graft and multifocal subacute myocardial infarcts. You see that?
Yes, sir.
Mr. Saunier's past medical history was significant for obstructive sleep apnea syndrome, essential hypertension, coronary artery disease involving native coronary arteries of the heart. You see that?
Yes, sir.
And thrombocytopenia, right?
Yes.
So the pathologist too agreed that Billy Saunier was suffering from thrombocytopenia, right?
Yes.
You agree that the medical record showed mild edema?
Check form.
You may answer.
Where in particular?
Show you what's been previously marked as Exhibit 11.
It would be 12.
I'm sorry, 12. Thank you, Madam Court Reporter. So you're saying you don't recall that, right?
No, I'm asking where you talking. I mean, it could be in the lungs, it could be the legs, it could be like, which edema are you referring to?
Do you recall seeing edema or not?
Yes.
Okay. For the record, we're looking at Billy Saunier's medical record, page 83. You see that?
Yes.
This is 11:20, 8:27 in the morning, 8:22 in the morning. So that's 2 days post-op, right?
Yes.
It reads abdomen soft, extremities, mild edema. Do you see that?
Yes.
Is that a potential sign or symptom of heparin-induced thrombocytopenia?
No.
Okay. Pedal edema, you recall that?
Yes.
Do you agree pedal edema can be a sign or symptom of heparin-induced thrombocytopenia?
No.
Rash, you recall a rash?
Yes.
You agree that a rash can be a sign or symptom of HIT?
No.
Dependent edema,
No.
mild edema,
No.
rash on chest?
No.
Show you what's been previously marked as Exhibit 13. Do you recall seeing these texts?
No.
You were not provided with these that you recall?
Not to my knowledge, no.
I'm going to scroll down to January 25, 2018, 10:15.
Yes. See it.
It's from the, the recipient is the hospitalist. See that?
Yes.
Well, let's start with 9:58 p.m. The recipient is cardiovascular disease. Is that right?
Yes.
And the recipient's name is Shannon Dugan.
Yes.
Here it reads at 21:15. That's 9 or 16. Can you blow that up a little bit?
There
Is
we
it
go.
better?
Okay.
Yeah,
That's better. Thank you.
thank you. At 21:16, the patient had a 10 run of VTAC, stated that he felt lightheaded and crummy. Crummy? I don't know how to spell crummy. Vital signs are stable. Symptoms have resolved. Want to do EKG. You hadn't seen that before today?
No, I saw it in the or read it in the deposition,
Okay.
but
And
not
do
this
you agree
actual
that-
document.
I apologize. You agree that lightheaded can be a sign or symptom of HIT?
No.
Objective form.
Okay. And then later at 10:15, a hospitalist as a recipient. Patient located BW 737. Have you ever been in this hospital?
No.
Okay. 21:16 patient had 10 run of VTAC, stated he felt lightheaded and crummy. Vital signs are stable. Symptoms have resolved. Want to do EKG. Looks like there was no response between these two. Is that right?
Objective form.
I'm not sure how their message system works.
Okay.
Yeah, I don't know if they can reciprocate messages or if they're more for information.
Any reason, according to this document that was provided to us, this is message detail 11/15/2018 to 11/27/2018. So that would include, the entire medical record we're talking about, right?
Object to form.
Yes, the dates are correct, yes. Mhm.
So any reason to believe that WellStar Keystone Hospital would have given us a false or fraudulent message detail?
Object to form.
No, what I'm saying is, I don't see answers to the particular messages as they go out, so I'm not sure that this system allows for that.
Okay.
There are certain medical apps that you can send messages on, but you don't respond in the app. You either call or go to, or like, are there any that show the response like right behind it?
Yeah, there are.
So they do have the ability to do that.
So I think the last one we did was 1051 to 1053. Is that right? No, let's do that. Same day, all the 11/25, 1051, 37 p.m. Hospitalist to Salome Mignori.
Yes.
Looking at printed, I'm sorry.
I just said yes. I see where you're at.
Looking at printed rhythm strips from past couple of days. So that means this is like 2 days now, right?
Yes.
I've noticed possible slight ST elevation. Do you want to reconsult CVM? You see that?
Yes, sir.
You didn't see that before today, right?
Only in the depositions,
And what is a CVM?
cardiovascular medicine. So the cardiology team.
And I think this next one may answer your question.
I
It's
see that,
now,
yeah.
yes, ma'am. It's now 3:44 in the morning on 11/26. This is the day that Billy Saunier dies, right?
Yes.
And this is a response, it looks like.
I think the one beneath it is the response.
Yes, ma'am.
Yeah, I see what you're saying.
My
Yes.
apologies.
So I
Hosp-
agree the other ones weren't answered, yes. Not
Oh,
answered in the app, in the messaging.
one more time, though. I missed the first part of your answer.
I said, so I'll go back and say I agree the others weren't answered in the messaging format.
Ha Salom, and I'm not sure about the pronunciation. I just wanted to let you know.
Mignori.
What's that?
Salome Mignori.
Salome Mignori. Thank you, Heather. Hi, Salome. Just wanted to let you know that for Billy Saunier, who is now in B354, that we never got him back. His time of death was 2:48. The hospitalist group was primary. So completion of this discharge summary will fall to you guys. Thanks. You see that?
Yes, sir.
You agree that Billy Saunier's platelet monitoring indicated a progressive and concerning decline?
Yes. After the peak, yes. It did the bimodal thing, but afterwards, yes, absolutely.
And that's common. That can happen in a patient suffering from HIP, right?
Yes.
You agree that HIT was suspected as early as November 24, 2018?
Object to form.
I do believe, yes, 11/24. That's when they first started mentioning it, the low platelets, yes.
And the lab was ordered nearly 24 hours after the first documented suspicion of HIT on the 25th.
Yes.
I'm going through my notes. I have no interest in re-asking you the question, the stuff we've already covered. I assume you have no interest in re-answering.
I'm good, thanks.
You agree that institutional policy, the policies and procedures that we looked at and national guidelines emphasize urgency in suspected hit cases to avoid fatal complications?
I did,
Patient.
yes,
There was nearly a full day delay between suspicion of hit and ordering the test.
Object to the form.
You may answer.
no. Not suspicion, concern.
Okay, concern. And you agree that the nearly 20-hour delay from the concern to ordering the first hit panel placed Billy Saunier at increased risk for thrombosis?
Form.
You may answer.
No.
Well, how's that? If he had hit?
You're my understanding was you're asking me, did I think that the delay in ordering the test, I don't necessarily think that the test ordering was delayed or that it was inappropriately delayed. I think they were following the platelet count and ordered it at an appropriate time.
So you can have suspicion or concern and wait a day or so to order a hit panel?
Yes, it wasn't defined at that time, in my opinion.
Okay.
It certainly went up on the radar, why is this man's platelets dropping, but not enough for me to have said, we need to get a hit test.
And it not only went up on the radar, it also went into the differential diagnoses, right?
Yes, sir. I agree.
And you agree that national guidelines recommend ordering the hit panel as soon as there's a clinical suspicion?
Again, with the caveat that your probabilities are intermediate or high.
Okay. You agree that the optical density for the hit panel 3.501 indicates a strong positive result for heparin-induced thrombocytopenia, heparin-induced antibodies?
Yes, I do.
You agree that the medical team discontinued the heparin after the platelet drop?
Yes.
And that was per their notes. That's why they DC'd the heparin, right?
Yes, sir.
And between the time they discontinued the heparin until the time of his death, there was never a non-heparin anticoagulant administered, right?
No, there wasn't.
You're saying what kind of procedure did Billy Saunier have on the 15th of November, 2018? Heart procedure.
On the 15th, that he had a cardiac catheterization.
And heparin was administered then as well, right?
That's correct. Yes.
And that's 4 days before the 19th.
Yes.
And your testimony is that would have no impact on his predisposition to hit after his CABG surgery.
if I remember correctly, I testified that getting the IV heparin, it's not about the volume of the heparin or how long you get the infusion. That's what I recalled when I answered that question. Was it's not necessarily about, excuse me?
Oh, no, go ahead. I didn't mean to interrupt you.
Oh, sure. I was saying what I remember and interpret responding was that it's not based on the volume of heparin that you receive. Like if you're at risk for it, you're at risk for it by getting heparin.
And my question's a little different. Was Billy Saunier having had heparin on the 15th? Did that put him at increased risk for a hit after the surgery on the 19th, where he got heparin again?
Not to my understanding.
Any cite for that?
No, sir.
If this was your patient and you got back the 3.51 hit panel, which and you'd already discontinued the heparin, would you start that patient on a non-heparin anticoagulant?
I would call a hematology and ask them to jump on board and get it ordered, yes.
Okay. That's all I have.
No questions.
You be safe.
Thank you.
You too. Bye-bye.
And Karen, I'll take a copy, please, Etran with exhibits.
Okay. And
Do I
Mr.
need to
King?
stay on for you to get the exhibits, Karen? Or you mean just leave it on? Or you?
No, I think Ms. Cocker is going to send them to me by email.
Okay.
Karen, thanks, everybody.
Thank you.
Thanks.
Mr. King, did you want to purchase a copy?
Yeah, we'll take an E-Tran only.
Okay, thank you.
Thank you.
Karen? Hey,
Yes.
let me get your email because I've got those and I'm gonna send those exhibits over to you now.
Okay,
Thank you, Elizabeth.
You're welcome. What's your email, Karen?
it's office@acrga.com.
office@acrga.com.
Yes.
Okay, I'm gonna do that right now. And
Okay,
it's
and-
so
and-
great seeing you. Yes, ma'am. Go ahead.
It's great seeing y'all too. Happy New Year.
Happy New Year.
Did y'all want to purchase, order the original?
Yeah.
Okay,
Yes.
Electronic only.
right.
Thank
Yes.
you.
Thank you so much.
Thank y'all
Stay
so
warm.
much.
Okay, bye.
Bye.